Yes, that high-pitched, squeaky voice with a face for podcasting. It must be time for another Puscast, the first one covering the literature from 2010, a new decade of infectious diseases to thrill and amaze us all. This Puscast is going to cover the first 2 weeks of January 2010. Remember, this is on iTunes. My ongoing narcissism demands that you go write me a review on iTunes. Since this is CME accredited, when you're done listening to this babbling, take the online quiz and get a half an hour of free CME. Thank you, Legacy Health. I think they changed their name from Legacy Health Systems to Legacy Health. Then there'll be Legacy, and there'll be Le. They get shorter and shorter. But because this is CME accredited, I have to mention my potential conflicts of interest. None. Well, I do get a pittance from you kind listeners, so I guess that counts as a conflict of interest. However, for this decade, I am for sale. Feel free to come and buy my immortal soul. It won't be very expensive. And also to mention the rest of my multimedia empire, because the world needs more Mark Crislip. You can hear more of me on my Gobito Puss, on my Quackcast, both available on iTunes, and my blogs over at Science Based Medicine. It's not really mine, but I'm a contributor. And mine, Rubor, Dolor, Kalor, over at Medscape. But enough about me. Actually, there's never enough about me. But let's move on to the infectious disease literature. Because really, isn't that why we're all here? I shall start with an FYI for them what might be interested. The CDC has published a new vaccination schedule for adults. It's available over at the Annals of Internal Medicine, amongst other places. So if you are involved in the care of adults, then that's the place to go to get vaccine information and what your patients should consider. The tracking nanobots that the government now puts in the vaccine are much less antigenic and do not cause the same long-term problems. Plus, they can pinpoint you to within 6 inches using the satellites. And they're rechargeable by the contrails. So life is looking good. However, there were no really substantive changes in the what to give and when to give them. There's more fine points with the footnotes to explain the rationale of the vaccine schedule. The WNV, either that's the We Never Looked or the West Nile virus, is a bad disease in a subset of patients who go on to get encephalitis. Of those, a significant percentage, up to 60%, can remain symptomatic for years after their symptoms. Is this due to persisting viral infection? Well, in this series of patients out of Houston, Texas, they looked at the urine with PCR for the presence of West Nile virus, and they found it in 5 of what? 5 of 9. Boy, it sounds like a Borg, doesn't it? 5 of 25 patients. So it suggests that patients who have encephalitis and go on to get persisting symptoms have it in part perhaps due to ongoing viral infection. Chronic symptoms, by the way, are also associated with the persistence of anti-West Nile IgM, and they tend to have elevated levels of gamma interferon. Certainly, those would not be kidneys you'd want to give in donation for transplant. Maybe I'm reading too much into the next article. It was out of Pakistan, and they found a founder effect amongst their injection drug users. It looks like one person started the outbreak because all of the HIV in their IV drug users was 99.9% related. So they conclude that there was a founder effect, i.e. one person came in and started the epidemic in Pakistan. I like their conclusions, however. One is that specific measures need to be implemented to control transmission of HIV infection in Pakistan through infected migrant workers, because Pakistanis, of course, would never participate in any behavior that might lead to HIV disease on their own. And then, of course, Pakistan and India have never gotten along well, to put it mildly, and they want to make sure that They don't want to have a, quote, steep rise infection, not unlike its HIV-havocked neighbor India. I'm kind of surprised that the BMC Infectious Diseases let this through without a little bit more editing. I always remember the book the band played on, and they suggested that perhaps HIV came to the United States by way of an airline flight attendant. I actually don't know what the founder effect is in the United States, but there's probably, at this point, multiple strains circulating through the U.S. World's filled with awful cases, just awful, awful, awful. This guy's in Thailand, and he gets bit by a rabid dog. Well, he gets appropriate prophylaxis, both the vaccine and anti-rabies immunoglobulin. Yet, 25 days later, he presents to the emergency room, has progressive neurologic meltdown, and dies of rabies that was identical to the rabies in the dog that bit him. It wasn't a typical presentation, and he presented with, amongst other things, trismus, followed by limb weakness, areflexia, ophthalmoparesis, and bilateral ptosis, kind of like a tetanus that turned out in the end to be due to rabies. So rabies vaccine and rabies immunoglobulin, when given to people with exposure, is virtually 100%, but like everything in medicine, not exactly 100%. And there are other cases of rabies prophylaxis failure. Stay away from them, they're rabid dogs. Unless your name is Scout and your father just happens to be Atticus. He'll take care of that rabid dog for you. So, you're a healthcare worker. You work in healthcare. Where do you get flu from? Well, this study out of Germany looked at seasonal flu in hospital healthcare workers, and they found that the most likely place for them to get flu, for seasonal flu at least, was not the hospital, but from household contacts. And the other interesting thing is that a third of people serologically converted their infections but were asymptomatic for seasonal flu. The significance of this is that if you're a healthcare worker and you're not vaccinated, then you could pick it up at home and bring it asymptomatically to your patients and give them the flu. And if they had the wrong underlying conditions, they could then die of the flu. Who dies of flu? Well, pregnant women. I must be asked once or twice a week, should this pregnant woman, but I never get asked about pregnant men, be immunized with either seasonal flu or H1N1. The study out of California looked at the effects of H1N1 on pregnant women. They had 94 pregnant women, 8 postpartum women, compared to 137 non-pregnant women. If you were pregnant, you had a marked increase in your risk for going into the ICU or dying, the relative risk being 4.3 compared to non-pregnant women. And 8% of pregnant women died, which is a bad outcome. I mean, almost 1 in 10 pregnant women who get flu died of the flu. One of the things that was protective from death and ICU was receiving antiviral therapy. Those whose antiviral therapy was delayed by 48 hours had 4 times the risk of ICU stay or death. So, if you're pregnant, it's probably a good idea to get the flu vaccine or the H1N1 vaccine, especially if H1N1 comes back. Oh, and good news, there was a case of H1N1 that was spread to a cat from a human being. The cat, unfortunately, survived. In case you're wondering, at the end of the year, what the current CDC estimates are for H1N1, they think anywhere between 39 million and 80 million Americans got flu, with the average they estimate being 55 million. They think somewhere between 173,000 and 362,000 people required inpatient care, with the average being about 246 in the estimates. They think anywhere between 7,800 and 16,400 people died directly or indirectly from influenza, with the median estimate being about 11,000. They think about 28% of Americans had the vaccine, which means there's still a significant proportion of the population still eligible to get both the vaccine or, even worse, influenza. Now, I don't have the background to truly understand this article, but it is fascinating nonetheless. It's entitled Syphilis at the Crossroad of Phylogenetics and Paleopathology. These people tried to figure out where syphilis came from. They had three hypotheses. One, it was 500 years old and came to Europe with Columbus. Two, it's been around as long as man has. Or three, is it about 5,000 to 16,000 years old. They looked at both paleobiology and they compared the rates of known syphilis genetic changes. And they estimate that the probable source of syphilis is about 5,000 to 15,000 years ago. And that perhaps this is associated with man coming to the New World and getting syphilis there. Pre-Columbus, not with Columbus. So this is a very complicated article, but the entire article is free online, and it makes for fascinating reading. And it suggests that syphilis is probably not as old as man, but you can't blame Columbus either, although you can blame Columbus for a lot. Part of the argument is that syphilis has been seen throughout the world and been misdiagnosed as other diseases such as leprosy. Whether that's true or not, I do not know. But it makes for an interesting read about the history of syphilis. Nothing is sweeter than evidence. A good clinical trial. For years I get these phone calls. My patient's going to have a dental procedure and they have an artificial hip, they have an artificial joint. Should I put them on prophylactic antibiotics? And extrapolating from the endocarditis literature, where most of it suggests it doesn't work either, it is been suggested that patients with artificial hips get prophylactic antibiotics. Well, this study was done in a 1,200-bed tertiary care hospital in Rochester, Minnesota. I wonder what hospital is in Rochester. You know, when I did my residency in Hennepin County, Minneapolis, we always used to say, hold the Mayo. So they compared 339 patients with infections of prosthetic hips or knees, and they compared them with 339 control subjects. And they found that the dental work made no difference. Quote, dental procedures were not risk factors for subsequent hip or knee infections, and the use of prophylactic antibiotics prior to dental procedures did not decrease the risk of subsequent total hip or knee infection. There we got it. A clinical trial. You don't need to give prophylactic antibiotics to patients who are going to have their dental work done and they have the presence of an artificial joint. Yee-hee! Hooray for science! The important thing they point out is that it's good dental hygiene and clean teeth that prevent infections. So quit using your meth. There was a case report of a patient who had 3 weeks of right upper quadrant pain that was diagnosed as a gastric ulcer. It did not get better. He developed fever and back pain and then lower limb weakness, and was subsequently found to have a T5-6 epidural abscess, and that the first symptoms were neuropathic radiating pain. I mention this because I saw this once before myself, an elderly lady who presented with right lower quadrant pain and got the usual abdominal pain workup for 4 or 5 days with no answer until she started developing weakness, and it was found that this was neuropathic pain from her epidural abscess. It is a rare complication, but they found it in China. I've seen it in Portland, so I mention it to you. Surgical wound infections used to be part of how I paid the mortgage. If you pay attention to these New England Journal of Medicine articles, I think soon I will be standing at the freeway off-ramp with a sign that says, "We'll do infectious diseases for food." The first study in the New England Journal of Medicine compared chlorhexidine alcohol versus povidone iodine for surgical site antisepsis. and the chlorhexidine was vastly superior. There were 4.2% superficial infections in the chlorhexidine group, double that in the povidone iodine group. There was 1% infections in the deep incisional space in the chlorhexidine, 3% in the povidone iodine. In my institutions, we switched to chlorhexidine a long time ago, but really, if you have a surgeon who is still using povidone iodine after reading this study, they need to go practice in a hospital that's not yours. They've proven themselves to be morons. The other study in the New England Journal of Medicine is more problematic and concerns screening people for Staph aureus. In this study, they screened people with nasal swabs for Staph aureus, both MSSA and MRSA. They used a PCR to make the diagnosis. So this is just nasal swab. And you know, if you've been listening to this podcast, that you now have made the diagnosis of staph carriage rates, but staph can also be carried in the retropharynx, the armpits, and the rectum, as well as skin folds. So you have picked a percentage of patients with staph, but there's still a probable significant subset of patients who are carriers of staph that you have missed. It's one of the reasons I'm not enthusiastic about nasal swabbing to identify patients. I think it gives a false sense of security as to who does and does not have staph. However, those that were positive were randomized to get mupirocin ointment up their nose and chlorhexidine soap for 5 days. The result was, again, a marked decrease in the infection rates in those who were staph carriage who received mupirocin nasal ointment and chlorhexidine soap. The rates in those that were treated were 3.4%, whereas those who had placebo were almost double at 7.7%. So should we be screening all our patients for staph and then treating those that are carriers, or would it be wiser just to give everybody a chlorhexidine bath as well as a wee bit of mupirocin up the nose? Part of the problem with mupirocin, of course, is that we have 14% resistance in some parts of the country, or at least the world, to mupirocin, so that may be losing its efficacy. Certainly if you're showering, you could put a little of that chlorhexidine soap up your nose as you bathe. I'm kind of thinking personally, and I don't know what the cost effectiveness would be, that it's probably better just to give everybody chlorhexidine showers before their surgery rather than just do it for the people that have staph up their nose with a rubber hose. Quick, name that TV show. I got these issues that I keep harping on this podcast and in other places. Inflammation is good. It kills infections. Inflammation is bad because inflammation is a pro-inflammatory state. When some wackaloon says you're going to boost your immune system, you have to ask yourself, are they actually suggesting that I induce an inflammatory state, a pro-inflammatory state, as, quote, boosting my immune system, unquote? Because the wackaloons like to say that a lot. You should boost your immune system, which to me looks like an inflammatory response. And often the articles that they quote show an inflammatory response. And inflammatory responses are bad. If you boost your immune system with, say, probiotics, you're becoming pro-inflammatory. Well, what's the problem with that? Well, for tuberculosis, if you have tuberculosis, you have an increased risk of stroke and you have an increased risk of heart attack compares to those that don't. Your risk for stroke is twice that of those who don't have tuberculosis, and your chance of developing a myocardial infarction are about 1.3% higher if you have tuberculosis than if you don't. Now, this applies to more than just tuberculosis. In a study that looked at patients in Manhattan, having an infectious disease increased, although a small amount, your relative risk for a stroke and other vascular events. And what were the infections they looked at in this study, you ask? Chlamydia pneumoniae, Helicobacter pylori, CMV, HSV1, HSV2. Again, the relative risks for tiny, relatively speaking, about 1.39 for the adjusted hazard ratio per standard deviation. Doesn't make any sense to me, but people like that kind of crap. If you had those diseases and if you didn't. Inflammation, good and bad. Everything in medicine is good and bad. except perhaps for Medicare reimbursement for ID doctors, which is only getting bad. One of the current mantras of the anti-vaccine wackaloons is too much too soon, notwithstanding the fact that the number of antigens in the vaccine has decreased dramatically over the years. They seem to think that infections and life does not expose you to antigens, but the piddly-ass amounts you get in a vaccine are somehow dangerous. This study looked at the immunogenicity of toxins to Staph aureus infections, and they looked for antibody response to a variety of toxins made by Staph aureus. And they found that with the staph infections, people make antibodies to about 17 of the toxins. Now, that's just the toxins. That does not include the cell wall constituents and other things found in Staph aureus. So that the antibody response that the immune system has to Staph aureus in and of itself is probably equal to the amount of antigens you get in all your vaccines combined, which is about 30. Too much too soon, my derriere. One of the things that we have done at our hospitals is put into place all of these protocols and bundles to try and decrease nosocomial infections, and they have been, unfortunately, very successful. The VAP rates at some of my hospitals have fallen to zero for a year, which is quite remarkable. An abstract published at the Critical Care Conference this month showed equal benefit at a hospital in Tennessee, where their ventilator-associated pneumonia rates went from 34 episodes in a year to 4 in a year. And they reported 10 months where they had no VAPs at all. And yes, that can happen to you too. What do you do with these protocols? Well, you keep the head of the bed 30 degrees, you give oral hygiene, you do DVT prophylaxis, you do GI prophylaxis, you get the patient off the vent as soon as possible, and you make sure that they are adequately sedated when they have vacations from sedation. This also is associated with the multidisciplinary rounds where everybody talks about what needs to be done to get the patient better. And it's amazing the benefits that this has on patient care, and similar decrease in line-related infections and urinary tract infections have also happened in my hospitals. And it can happen at yours too, if you haven't done it yet. I used to think there was an inevitability to hospital-acquired infections, and now, with the exception of fully associated urinary tract infections, I think virtually all hospital-acquired infections can virtually be eradicated. People are always suggesting that fried food is bad for you. Well, fried food sterilizes your food. Now, where do you get the E. coli that causes urinary tract infections? Now, it's been spread within the family, and I've talked about in other podcasts how the family dog has been a source of E. coli in the family members. But it turns out from this study that part of the source of the E. coli that people get is from food. What they did was they took 353 strains of E. coli from urinary tract infections, 417 strains from retail meat, and 74 from restaurant or ready-to-eat foods. And they compared them by both antibiotic susceptibilities and a variety of genotypings. And they found that the organisms that was found in the retail chicken and in the honeydew melon was indistinguishable from the E. coli in the human urinary tract infections. As they say as a conclusion, this study provides strong support for the role of food reservoirs or food transmission in the dissemination of E. coli causing common community UTIs. I've said many times that everything you eat is covered with a fine patina of human poo. This is yet another study that confirms the importance of deep frying your food. Google images for acupuncture, and you'll see all these fingers sticking needles into the skin without gloves. It gives you the willies, I'll tell you, if you do infection control as part of your job, or even if you believe in germ theory. I've talked before about infectious disease outbreaks due to, amongst other things, acupuncture. And here's another one. This one was with Mycobacterium abscessus, where they had 109 people who got cutaneous infections due to Mycobacterium abscessus as a complication of their acupuncture treatment. They found acupuncture in 9 environmental samples, including a glutaraldehyde solution that was used for disinfecting the physical therapy materials used in the clinic. But one would think if they were using, sterile technique, maybe that wouldn't have happened. But really, are you going to expect people that do acupuncture for a living to actually understand germ theory? I think not. There are 2 cryptococcuses, Cryptococci, that cause disease in human beings. Cryptococcus neoformans, Cryptococcus gattii. Gattii has been having a big outbreak in British Columbia and Vancouver Island, just north of the Great Pacific Northwest. And it supposedly got here from Australia/New Zealand. However, this study looked at the extent worldwide of Cryptococcus gattii, and they found specimens in Argentina, Brazil, Colombia, India, Egypt, Italy, Mexico, and the United States. This organism has a specific ecological niche, of course. It likes trees, especially eucalyptus trees, and it likes the hollows of trees. And since this organism kills people, it's a deathly hollows. Maybe Harry should have been looking for Cryptococci instead of a wand, a cloak, and a stone, although things turned out okay in the end, I suppose. The take-home message, though, is that Cryptococcus gattii probably has more widespread distribution than you suspect. And if you have a case and you're not in an endemic area, you might want to have your organism looked at to see exactly which Cryptococcus it is, as it does require special testing. And now comes your favorite part, the hodgepodge. 1, if you have extended spectrum beta-lactamase producing E. coli and you're septic, you have an increased 14-day mortality. So this is a bad thing to get when compared to non-ESB producing E. coli's. The use of the pneumococcal vaccine, 7-valent, the one used in kids, has led to a sustained decrease in invasive disease due to these strains from 24 per 100,000 to 13.5 per 100,000. And although other organisms have increased, not to the point where they have taken over the prior ecologic niche of the other pneumococci. There are some Prevotella in France. These are anaerobes that are metronidazole resistant. It's unusual, but there's a gene called the NIM gene that will do this in Prevotella. Tumor necrosis factor blocker therapy increases your risk of histoplasmosis. Duh. We all knew this, I hope, but it is a 3-fold more common than TB in patients receiving tumor necrosis factor blockers, and you can find the details for that in CID. Linezolid is effective in treating multi-drug resistant tuberculosis, although all the patients go bankrupt in the process. Solid organ transplants who are on statins have decreased mortality from bloodstream infections than those that are not on statins. I'm starting to think everybody should be on prophylactic statins and birth control pills. And finally, one of the ways they're using to try and get rid of malaria is by infecting the mosquito with Wolbachia. Wolbachia is a bacteria that they're using to try and control malaria. Quote, Wolbachia strain reduces insect lifespan. Wolbachia is an inherited bacterium able to manipulate the insect's host's reproductive biology in a manner that promotes its rapid spread through insect populations. Releasing Wolbachia-infected mosquitoes could initiate an invasion of Wolbachia into the wild mosquito population that results in reduced lifespan of wild mosquitoes and could theoretically greatly reduce transmission of dengue virus. This is because only old mosquitoes transmit the virus. In addition to the lifespan reduction, we have recently shown that Wolbachia infection substantially reduces the dengue load in mosquitoes and reduces their ability to successfully obtain blood meals as they age. This study looked at human probing behavior of mosquitoes when infected with Wolbachia, and they found that these infected mosquitoes had increased difficulty in completing the process of blood feeding effectively and efficiently. So this may be a cool way of eventually controlling dengue and perhaps other mosquito-borne infections. Remember, it's been estimated that half of everyone who's ever died has died from a mosquito-borne illness. Now, if you like pithy sayings and aphorisms, please go to the January 1st, 2010 Emerging Infectious Diseases and download an article called Some Haphazard, I can't say that as a rule, Some Haphazard Aphorisms for Epidemiology and Life by John M. Cowden. If you need a quick, funny saying, this is a great collection of medically related aphorisms and well worth your time in reading. And that's it. Another Puscast is in the toilet. Now that you've listened to this, of course, you can go and get some CME by taking my remarkably easy CME quiz. This is brought to you by Plusware LLC, the publisher of the Persiflager's annotated compendium of infectious facts, dogma, and opinion. Your uber hyperlinked electronic guide to infectious diseases at Pusware.com. Don't forget to feed my narcissistic ego and write me a good review on iTunes. Come on, get around to it. Let the world know how stupendous I am. And don't forget the rest of my multimedia medical empire, the Quackcast, the Gobado Pus, Science-Based Medicine, and Rubor, Dolor, Kalor, Tumor. It's a wonder I even get time to go to the bathroom. Bandwidth ain't free, so feel free to purchase the compendium and support the podcast. I thank everyone who has donated to my overhead. It's greatly appreciated. This is copyright under the Creative Commons license for 2010. The music is by my son when he was 12, improvising on the guitar. Email me all you want. I now have, I think, 2,000 unanswered emails. They just sit on my Gmail account, making me feel guilty. But I can either answer emails or come up with new stuff for my multimedia empire. So I choose the empire. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most interesting case. I will continue to follow along with you. Thank you. In dictation. Goodbye.